Hello, everybody. This is episode number 5. I have an awesome guest tonight, Bill. Today, we have Dr. Bill Egan. He is an associate professor of instruction for Temple University's DPT program, my alma mater. Bill was my instructor. He's been there for 12 years, and he's also the director of the orthopedic residency program. Bill is also an Army veteran. He was a former Army physical therapist. And so today we're going to be talking about his experiences in the outpatient orthopedic setting, not only his personal experiences as a treating therapist, but also now that he is an instructor in the DPT program, how just some of the challenges that students and instructors and clinical instructors go through trying to transition what we learn in the classroom to what's actually happening in the clinical setting. Bill, it is first of all, it's so good to see your face. I haven't seen you since CSM.
That's right.
And yeah, quarantine, life. So you've probably been doing a lot of this, right?
I have. Yeah, I'm a Zoom veteran at this point.
Yeah. So how has this affected, how has COVID affected Temple, and how has everybody transitioned?
Yeah, so I think we went into quarantine the week of St. Patrick's Day. So as soon as that happened, all classes went online for our DPT program. Obviously, we stopped any face-to-face instruction. So our labs from the spring, we had to kind of postpone them. We were like right after spring break, and then we have summer class. Our program goes in the summer now, and we started the summer classes online. And just last week, we went back into the lab. So any class that has a lab to it, we're doing that face-to-face, but the lecture piece goes online.
Okay, interesting. So, so you're talking about year one, the new cohort of students.
Mm-hmm.
Okay, and probably the year 2 going into their second years are finishing their labs. Okay.
Right. Yeah, and the year 2 now they have classes in the summer. The curriculum's a little different than when you were there, Katie.
Mm-hmm.
So they take their first musculoskeletal and clinical neuro classes in the summer. The second year students do.
Okay. I can't even remember.
Yeah.
I seriously actually no, I do remember, because there was like a 6-week kind of get your feet wet clinical in the summer.
Right.
Yeah. Okay. It's coming back to me.
Yeah, we've gotten rid of they don't have that anymore, just because we didn't find it to be super valuable, just because it was like right after your first year, so you didn't have the clinical course background yet.
I would agree 100%. You could use it better elsewhere, probably.
Yeah. So on Monday, I taught a lab. We kind of broke the students into small groups, and then they have one partner for the duration of all lab courses. So they're kind of sticking with the same person, and then they're in the same groups for all lab courses. And we were wearing masks, face shields, and gloves. So we're like taking the maximum precautions. There, within the university, there's signage up, there's arrows, and all these different things. So I feel pretty good about our return to face in terms of like the safety measures.
I think that's great. And honestly, so when COVID started, I kind of stopped all of my patient care for safety, but also because my kids were home, and I kind of have to take care of them. So nobody else could do that. But then returning to things, so I had an N95 that was donated by this, it was PGH or PPE Connect PGH.com, and they actually delivered an N95 mask to my house, but I only got one. Nice. But they don't have them anymore. So now that actually in Allegheny County, so just so everybody knows, our listeners, Bill is in Philadelphia, or actually Haddonfield, New Jersey, and so I am in Pittsburgh on the other side of the state, and Philly had COVID outbreaks a little bit more intense right off the bat, and Allegheny County, Pittsburgh area wasn't that bad, but now we're actually seeing an uptick in all of our cases. So it's like there's a lot of people that are taking more precautions now, and there's like less face masks available. So
oh boy. Yeah.
So I think that that's great. I think that the reason that New York is probably doing as good as they are is because they are taking like the maximum precaution. But I participated in a focus group last Thursday evening on like, and there was 2 girls, and it was all on physical therapist perception of working during the pandemic.
Oh, wow.
And there was 2 inpatient acute care physical therapists in Florida, and they were just like, we are at max capacity. We get way more numbers per day, and they're doing like, N95, face shield, 2 gowns, like however many sets of gloves, and so it's all crazy. It's just crazy.
Oh, it's crazy. And our students in the clinic had to be pulled, like our 3rd-year students that were graduating. And so some of them were pulled, and then the CAPT accreditation kind of loosened the guidelines on how many weeks he needed. So some of them were able to graduate on time. Others had to go back and make up some time. So they had to like delay their graduation a little bit. So it's been hectic.
Well, and also, so I submitted, the HIP course to the state board to get CEU approval. Have not heard anything back. They shut down their phone lines. I can only imagine how hard this is for students, new grads trying to take their licensure exam, trying to get like any sort of, how's that been?
Yeah, it's been the same thing. I know there was something that we needed to send. I forget it might have been to the state board or maybe to the NPTE board with like a graduation verification. We sent it in, but then someone didn't get it. So there's, all those kinds of things are, those administrative things that are normally go relatively smoothly have been backed up.
Man,
so I feel bad for the people that just are graduating. It's definitely a tough time right now for them.
Yeah, for sure. So speaking of tough times, I feel like this is going to be like a depressing episode, but it won't be. No. It'll be good. I would love for our listeners just to hear your take on your background, kind of how you started your PT career and how you ended up in education, and just give me your background.
Okay. Yeah. So I did the Army Baylor program for my entry level. So I graduated from that in '99. At the time, it was a master's in PT. I didn't know a whole lot about it, or really even. I thought it would be a good thing to do to go into the military. I'd heard good things about the program. You don't have to pay for it, which was the best part about it.
You get paid through it.
You get paid while you're in it. So. And my class was it was nice. It was only 21 students, and we had an awesome faculty. I mean, we had.
Who were your faculty?
Yeah, so we had Tim Flynn, we had Steve Allison, we had Colonel Moore.
Wow.
The
bros, like the big wigs.
Colonel Jeannie Bryant. I mean, it was awesome. I mean, just the faculty that, like I said, we had so much exposure to them as small class sizes. So it was really, really good. At the time, it was an 18-month program, which was a year in the classroom and then 6 months of clinicals. So it was super intensive, but you're getting paid to be there. So it's essentially your job. You're there in school from 7:30 to 4:30, 5 o'clock, Monday to Friday, exams every Friday. So it was good. It was definitely a choice that I would make over and over again if I had to do it over.
That's good.
Yeah. And then I served in the military as a PT for, I think my total commitment, including school, was 6 years. So I did that, and I was at Fort Knox, Kentucky, which was awesome because that at the time was a basic training post. Mm-hmm. And it was also the armor and cav school. So it was like all training there. There was I think there was like a couple small active units that deployed, but it was all training. So, definitely a lot of work in the troop medical clinic, seeing acute musculoskeletal injuries, a little bit of work on like injury prevention and that kind of stuff. So that was a great experience to kind of start off my career. Just getting really efficient at doing acute musculoskeletal evaluations and triaging people and ordering imaging and all that cool stuff that, haven't really got to do since I left the military.
Yeah, I had this very much the same experience at Fort Sill as a basic training installation, and the the Fires and Air Defense Artillery Center of Excellence, so tons of training, and you just see
similar
a huge volume of patients, and you get very efficient very quickly. So I would never change anything about how I started my career. It was probably the best thing that I did. Yeah.
Yeah, no, I really value that experience, and I draw on it today with practice and teaching all the time. So it's definitely a great way to practice. And I do think there's areas in the country civilian wise that are starting to kind of go that way, but they're kind of few and far between. I'd still like to see us get more autonomy and maybe see our professional role a little bit differently, at least, coming from that perspective of being in the military or serving as a military PT.
Yeah, so it's interesting that you say that, because this is going to be part of our discussion tonight is where does that come from? Does it come from a cultural understanding? Does it come from the way that we're trained? When I say we, I mean the majority of DPT education in the country. Does it come from that? Does it come from just this is how we do it, this is how we've been doing it for the longest time? Is it insurance driven? So like, I kind of want to get into the nitty gritty of what your thoughts are. Sure. And just open up that can of worms.
Yeah, I mean, I guess a good analogy, it's like low back pain. It's multifactorial.
Yeah.
Cause to it. So yeah, I mean, I think all the things that you already mentioned are causative factors in the way that PT is practiced today, at least in the U.S. And we'll say that we're talking about outpatient ortho, because that's really what we do. I don't want to necessarily speak for other areas of practice, because that's not my experience or expertise.
Yeah. So just to recap for other listeners that are not necessarily physical therapists, currently the state of PT in our country, in the United States, is it is generally not common practice for physical therapists to order their own imaging, to generate referrals to specialists if need be. And it's generally this thing where we can, I don't even say this because I don't even practice like this, but it's kind of this commonly accepted thing that you refer back to either the primary care provider or the person that referred the patient, the provider that referred the patient to you, to deal with anything outside of what's considered our scope of practice. And I've dove pretty deep into the weeds with this. Getting out of the military for me was a very difficult transition, because I did not even understand the way that PTs in the outside world, I didn't even understand it. Not only from coming from military to civilian, but coming from Temple, which is, I think that Temple's orthopedic education, or the educational program, is actually pretty progressive. And I don't think that most outpatient orthopedic PTs practice like that. So you taught me, Bill. You and Scott Burns and Heidi Oja were,
It's my fault.
right. So like, I am curious as to like, well, let's go back. Let's go back to, you came out of the Army as a PT, and then what? Like, then what, and what was your experience?
Yeah, that's like you said, it's a tough transition into the civilian world. I first practiced in an outpatient hospital clinic, and I actually liked that quite a bit, because it reminded me a little bit of like when I was in the military. I practiced like a troop medical clinic, but then we practiced in the hospital too, like in their outpatient. So it wasn't too dissimilar to that. Because when you're in the hospital setting, you're not doing as much direct access or imaging or anything like that. So I enjoyed that for the most part. And because it was a hospital clinic, and the director was pretty progressive. They didn't push us on billable units and seeing people for so many visits. It was kind of just like, do what you need to do. And if the patients are getting better and they're happy, then you're good to go. So I really like that job, but I didn't stay there for very long, because I think we were in Massachusetts, and my wife didn't like it up there, so we moved back to Jersey.
Dang spouse.
We had a couple of kids, and she wanted to be closer to the family and all that. So we moved, and I was sorry to leave that job. And then I bounced around a couple of different private practices, and that was certainly eye-opening for me about that world and how it works.
Hey, be raw. Let's hear it. Let's hear about it.
And once again, I don't think I wasn't in any shake and bake or mill kind of clinics where, it was 1,000 patients all the time. But still, I think things are more driven by the finances than anything else. And the insurance reimbursement, unfortunately, sort of dictates that. That's probably why when you're working in a hospital setting, it depends on the setting. The hospital settings tend to not be that way as much because they tend to get reimbursed at a higher rate per unit. That's just kind of the way it works with the hospitals in the U.S. They have a little more bargaining power compared
with the insurance companies.
So
for people who don't quite understand this, which me as a student and as a PT in the military, no idea, like totally oblivious to this kind of stuff. Mm-hmm. I understood how the military productivity worked, which there is productivity standards in the military as well. People don't realize that. However, the way that insurance companies work and how providers get paid, if you're a part of a hospital system, then typically that hospital system, just like Bill was saying, has more bargaining power when they come to the table with each individual insurance company as to what rate they're going to reimburse each service. So, but a private practice, let's say I just wanted to open up, well, I did open up my own PT practice, but decided to not get a network with any insurances. But let's say I did. If me, Katie O'Bright wanted to get in network with UPMC or Highmark or whatever, I am just one person, one PT that's like in this massive, saturated network of a bunch of other PTs. UPMC could be like, all right, we'll give you this much, and that's it. You are the idea of coming back to them and saying like, oh, I'm not going to accept that. They'll just be like, all right, see ya. Yeah. So I just wanted to explain that for listeners who don't understand. Yeah. But so you liked the hospital setting. They got reimbursed at a higher rate, so they're able to see less patients per day or a lower volume. And then private practice, tell me about that.
Yeah, private practice, there's definitely more onus on how many patients you're seeing, how productive you are, and it makes sense. I mean, you have to support your own salary, and there's overhead and all that, so I totally get it. It wasn't the way I like to practice that for the most part. But I did work for good practices where, for the most part, we would see, which I think is reasonable, you'd see a couple of patients an hour. Like you do a 30-minute follow-up, 45 to an hour eval. You're seeing maybe 12 to 15 patients a day. It's doable. It's not horrible. Certainly there's other practices out there that are seeing way more than that.
Like 4 an hour?
4 an hour or up to that. So, yeah.
So do you think that patient volume in physical therapy practice, or really in any type of healthcare practice, do you think that the volume of patients that you see per day has an inverse relationship to quality of care? So as the number of patients increases, the quality of care decreases. Would you say you agree with that statement?
Yeah, I mean, I think it makes sense. I mean, it's kind of, I don't know what that number is. I guess it's probably a bit of a sliding scale. And it might also depend on your patient population. If you're seeing maybe younger athletes who are relatively healthy and can kind of just follow an exercise program along and they might not need as much attention or supervision, you might be able to get away with being a little higher volume and still having good quality care. But if you're seeing more complex patients with comorbidities and psychosocial issues, all those things, that would be really tough to go high volume with that type of population. So I think it kind of depends on who you're seeing. But yeah, but I would say the statement that you made in general would be supported, like higher volume, particularly if your patients, the majority of their care is being provided by ancillary staff, I think you're going to see lower quality, meaning less improvement in outcomes per visit would be kind of the way we might define quality.
Okay, so on that note, and just to say what is ancillary staff, so typically the way that it works for people who've never been to PT, which a lot of healthcare providers that are even referring patients, their own patients, or they know that physical therapy is an option, they've never been to PT because the utilization rate for physical therapy services is really not that high. We would love to see it increase so that cost could eventually decrease, but that's a whole other separate can of worms that I'm not even going to get into. But the ancillary staff is basically, so you have your physical therapist that typically does the evaluation. And in my case, I do evaluation in all of the treatments, but you can have a physical therapy assistant, a PTA, who they have their own licenses, or a PT aide or a tech, or somebody who is not necessarily trained, but they work at the clinic. They're in some states they're allowed to run patients through their exercises, but not allowed to change the plan of care. It's different in every single state. So in a lot of PT clinics, there will be the main therapist that does the evaluation. They will write a plan of care out that goes for however long it goes. And then they will kind of follow that treatment plan for a given amount of time, 3 or 4 weeks or whatever it is. And then they'll maybe do a reassessment then.
Sure.
I have found that to be true. I've actually been to PT like 3 different times myself, and as a patient, just like growing up playing sports, and then as an adult, I had hip surgery, and even though I was a PT, I decided to go to PT. I had to. You can't treat yourself. You just can't. Because I won't do it. I'm just a lazy bum, and I need somebody to hold me accountable, which is the case for a lot of people. But anyway, if you go to PT, that's typically like you'll see your PT, they'll do this thing. And I don't know if I've ever practiced like that, ever. I had no idea. When I got out of the Army, I was shown the example that Medicare has for quote recertification of a plan of care. And I didn't even know, because the way that I practice is I do an evaluation on day 1. We come up with some sort of baseline treatment, a couple of things that you can do. On your next visit, I'm reassessing kind of the same the same things that we did in the first time that made a difference or reproduced their pain. Or so you're laughing because this is how you taught me. And so I'm reassessing how they're doing, their baselines, and then progressing and making adjustments to my plan based on that. And every time I'm doing some sort of assess and reassess. And I had no idea what a plan of care was, or a PT diagnosis. I had no idea that was any different than a diagnosis. So I think that there's a huge difference between what a lot of people are doing and then what maybe Temple's program taught me or what I learned how to practice in the Army. What are you finding when students you teach them this way? And then first of all, I want you to verify that is the way that you taught me and I'm not just a psycho. And then second of all, I want you to tell me what is your experience with sending students out in the clinic and then getting them back?
Yeah. I mean, we certainly teach that you're constantly reassessing. That's just kind of how that's the best way to treat patients. And that's why it's using ancillary staff, you lose out on that because you can, as a trained PT, you have the highest skill level to make changes on the fly, to progress a patient's program, to understand when it's time to scrap an exercise, add one, refer a patient out because something happened. All those things, because it's a constant process. It shouldn't wait for 30 days for the Medicare. And I think it's longer now, but
it's 90 to recert. Right, it's insane. We're laughing because it's who came up with these rules, or who came up with this model that doesn't make sense to me?
Yeah, so my experience in not only teaching entry level, but also working with our residents, and then I also have mentored fellows as well, is that the way that they are taught, it's very hard to find practices that sort of replicate that. They're out there, and definitely there's a lot of good clinics and a lot of good clinicians, but you know, as you know, in the Philly area, like, it's a competition for clinical sites. I mean, I forget how many programs we have now.
It's like 10.
Yeah, like
or something.
It's crazy so you're always competing for the sites. You try to find the good ones and stick with those, which I think we've done a good job with over the years. We tap into our alumni, we tap into our resident grads, you know, people like yourself. So,
oh, thanks, Bill.
Yeah, exactly. we kind of figured it out, but there's still times where the student will, call us up frantically and describe the way things are being practiced. It's not how they were taught, and it's kind of, not very progressive. Maybe lots of use of modalities, or everybody that walks in the door with low back pain has an SI joint problem, or
oh God, don't even.
We still run into that, but I think we've been able to sift that out a bit better as time has gone on. And I've been at Temple for a while now, but I would say with our residents, it's been funny. A lot of them will change jobs or open their own practice once they kind of get through with the residency, because they're like, all right, I was trained this way, and I really can't practice this way that I want. And I've seen the same thing with some of the fellows that I've worked with through Evidence in Motion as well. A lot of them kind of do something similar to you. They'll open up their own practice, maybe out of network, and so that way they can kind of treat patients how they see fit, and based on the way that they were trained.
I mean, I don't know if there's another way, to be honest. I think that there certainly are the clinics out there. Like the last place that I worked, that was in network. When I moved to Pittsburgh, I did work at a clinic. It was a multidisciplinary clinic. So it was a sports medicine physician, and a family medicine nurse practitioner and PT. And it was a really nice setup. And I had 1 hour one-on-one with all of my patients, every single one of them. And granted, like, I don't really know the finances behind the scene and everything, but I did like that model, and it was something that I certainly could sustain. But it was just a matter of, like, I saw myself going into a different direction. I didn't want to be seeing patients every single day, and that was just a personal preference. Sure, but I think that is a really nice model for like PTs coming out of school, especially if they're learning. And but it's just a matter of, like, how and why. How and why did we, like, get into this? Is it just insurance companies, like, running us into the ground and reimbursing us less and less and less as we're not only increasing in our educational level, but also, like, trying to do better care? I don't know.
Yeah, it's hard to say. I mean, I don't think it's only a PT problem. I mean, and in PT, what you do see is, because of the lowering reimbursement, a lot of private practitioners are selling their practices either to health systems or to the big corporate, like you're out here, we have NovaCare or something like that, or
ATI.
ATI, because they're able to absorb those costs a bit better. And also, I think they have a little more bargaining power when it comes to reimbursement too. So you're seeing that, and you see the same thing with docs as well. You don't see a ton of docs anymore in their own private practice. A lot of them work for a health system. Like in my area, I'm in South Jersey, which is right outside of Philly. Jefferson's buying up everything. They're all the clinics, everything. They're creating this huge health system health network down here. So you're seeing it across the board. So unfortunately, the way people practice is dictated by reimbursement. And then, folks like yourself say, I don't really want to be part of that. I'm going to go outside and the network and do my own thing, which is great. I guess the only problem with that is then the patients that can't afford those services,
out of pocket,
or out of network or whatever, where, what are they left with? So I think we definitely need to figure that out.
So I think that you just brought up a really interesting point, because I know I have a few friends actually that started, they had their own PT businesses and they've been absorbed by, like, in Pittsburgh, it's two big networks. There's no one else that exists. It's UPMC and it's Highmark or Allegheny Health Network, and
Right.
that's it. And every time UPMC opens a big health pavilion, AHN's right behind him opening another one right across the street. And it's just this, it's kind of this insane thing that is happening across the board with healthcare.
Mm-hmm.
Um, that the bottom line is it comes down to a business. They're not necessarily looking when they lose a PT, they're just looking to hire another PT, somebody who has a license.
Sure.
And granted, I'm sure that they have things in place to know, like, interview the right person and everything, but at the same time, it's like the big bean counters up at the top that care about the money, which is what drives the system. They just want to fill it with another body that has a PT license.
Sure. Sure.
And
Sure.
it just becomes this. I don't know. It's just definitely something that after learning more about it has nothing. I do not want to ever be a part of it.
Right.
And I will help my patients. I will help them file claims for reimbursement as much as possible. But I I just like there's no way that I can survive and provide the quality of care that I feel is necessary and is right, um, with only seeing a patient for 20 to 30 minutes. Like, and I
Sure.
think that I can take care of them in a much shorter period of time. Like, I can see a patient for an hour 3 times and get them better a lot faster in that 3 sessions than I could if I saw them, for maybe 20 minutes and then sent them over to a tech for the rest of the session over the course of 6 weeks. And
Yeah.
it's like, that's actually going to be cheaper for the insurance company. So I,
Sure.
I don't understand how it's sustainable. I don't think it is sustainable. And I just feel bad for.
I know. I think folks like yourself, I know you're tapped in with like fitness professionals. So I think that the other problem is we create this system where we're really just taking care of people for their episode of care, and then they sort of fall out. Where if, in a situation like yours, where you can see somebody and work with them, and then maybe they need a booster session, or maybe they're like, oh, I really want to continue exercising. They don't need you per se, but oh, I can recommend you to this person or this program, because a lot of the stuff we're doing is basic lifestyle things. That's what a lot of people need.
Mm-hmm.
Um, and I think we definitely talk a lot about it as a profession, but I'm not sure we're necessarily there yet in terms of like fulfilling that need and helping people out to be more healthy with their, whatever it's exercise, physical activity,
Sleep,
sleep,
behavioral health.
all that stuff. So,
Mm-hmm. And
uh,
I think that, like, as I mean, you brought up a big one. I could talk for days about all of that stuff, but the bottom line is, if you do address those things head on, you address, like, so people with chronic pain, we know that they have a higher incidence of depression, anxiety, sleep dysfunction, gut issues, obesity, and all of the things that we know don't make us well and healthy, right? So, like,
yeah.
as physical therapists and any healthcare provider, we should all be, like, at least assessing components of those as they relate to pain and somebody's physical dysfunction. Because if you address them head on and you just get somebody thinking about that, they're much more likely to pursue a solution to those parts of the problem.
Mhm.
And, like, I think that that's a no-brainer. But at the same time, earlier in the conversation, you had said that a lot of clinics, outpatient, maybe private practice clinics, are really driven by, like, hey, I need to fill my schedule. Let's
Right,
get you on here twice a week for 16 weeks for as long as your insurance will pay for it,
right.
type thing. So I
Yeah,
don't know, Bill.
yeah,
I don't know.
yeah, I agree. I think it doesn't foster patient sort of self-management. So, and that's what a lot of people, because most musculoskeletal things, unless it's in like an acute injury, they're chronic, recurrent problems, are long-term problems, and people need to understand how to take care of it, and use our help when they need, but also can they continue to lead a healthy lifestyle where they're going to have less incidence of that, or at least be able to better recover from it or be less disabled by it. And it takes a little bit more than just a one PT episode of care to do that for a lot of these, So there's so many conditions like chronic low back pain, knee osteoarthritis. I mean, those are two big ones right there that we know people have a tough time managing, because a lot of those are related to all those different factors that we just talked about.
Yeah, for sure. So coming back to our other conversation about students entering the clinic space, what is your guidance to brand spanking new students? They're off to their first clinical rotation. They know all of their foundations, all of their psychomotor skills, and they're just starting their first thing. Like, what is your advice to them, or you as a group of instructors, before they go off into their first clinical setting?
Oh man, yeah, that's a really good question. Yeah, I think the best advice we can give them is to not be afraid to make mistakes. Like, that's how you learn, and we hopefully we foster that within our educational program. It's like you got to put yourself out there. You've got to be willing to kind of try things and not be afraid to fail. And I think this could be a whole nother discussion. Student anxiety is a major problem right now, not just in PT programs, but in college and everything. And I think some of it stems from that. Is like this fear of failure and just always trying to get the best grade, and not necessarily, and that kind of impedes your learning. So I think the students that do well are the ones that can have some confidence in their abilities, and also just not worry too much about making a mistake. And hopefully they go with a CI in an environment that sort of fosters that. I know sometimes that CIs aren't always the best in letting students kind of feel that way, but hopefully that they can get there and feel like they're able to do that.
Yeah. So then on that note, really interesting, because the last two episodes that I recorded, the first one was with Colonel Jason Silvernail. Do you know Jason Silvernail?
Yeah.
Yeah. So, and then my cousin, Major Matt Sardo, who is a special ops infantry guy, and we were talking about leadership, and we were talking about growth and development, and how just how that affects people in leadership positions. And I kind of drew a lot of parallels, especially when I was interviewing my cousin, between being in a leadership position in any role, regardless of what it is, and being a healthcare provider and that relationship you have with your patient. So you're talking about student anxiety and their fear of failure and stuff like that. Have you noticed, you've been in academia for 12 years, have you noticed anything that has changed in addressing the students' abilities to or strengths in their ability to cope or overcome, or is there any sort of emphasis on like resiliency just as a person, rather than just all of the basic skills?
I wouldn't say a ton. I think we need to do a better job with that. I know we have a colleague that's been with us for a year or two, and she does a lot with mindfulness and runs a course for the students related to that mindful clinical practice, kind of related to those kinds of things that we just talked about. So I think that's a good thing. I'm not sure if that's like 100% successful, but I think it's a step in the right direction. But in terms of like the stuff you're talking about, I don't think at least in our program, we don't have like a specific course that sort of addresses those things.
Well, not even necessarily like a course, but just like almost a series of optional, or maybe not optional, maybe mandatory workshops, or like we used to do brown bag lunches at random times. The wheels are spinning in my brain right now, and I'm just like, I have these two things that I'm really passionate about, and I'm drawing, there are so many parallels between the patient and provider relationship, and how you can motivate them, and your ability to self-reflect and overcome and be confident and deal with your anxiety. And I don't know, I just feel like that would help students enter, and especially entering the workforce now.
Agreed. Yeah.
Just mother of God. I can't even imagine that right now. But like just these concepts of resiliency and like, were you in the Army when they were doing oh my gosh, MRT, master resiliency training? Like you
No.
have to do oh my gosh, so you have to do like how many, when I was in the Army and probably still now, you have to do all of these, 22, 23 modules of master resiliency training. And like when I was pregnant in the Army, believe it or not, they had additional resiliency training that I had to sit through. It was bullshit in my opinion, but anyway, I digress. But I do think that is an important component
Sure.
for, especially for healthcare providers, because like we're supposed to be the ones that patients are relying on. If we don't have control and like self-awareness, how are we able to implement things like motivational interviewing and like getting patients to be more self-aware and all that stuff?
Yeah, no, it's a big problem, and I think I think it's gotten a little bit worse probably since even when you were in school. I forget what year you graduated, but
2014. But how? Like, tell me about like that.
More incidents of students. I said patients that have issues with anxiety, and it comes off into the classroom and the clinic, and I think it's definitely a big problem. I mean, it's like I said, it's not just our program, our PT in general. I think it's undergraduate. It's my kids are in high school, or my daughter just graduated. Even in high school, it's pretty pervasive throughout society right now with kids and young people. And that would be a whole another discussion, but that's probably a multifactorial problem as well.
Yeah, totally. Well, we'll maybe save that for another time, because I think that actually would be a really interesting thing to look into, and
Yeah.
finding strategies to implement into education where students can learn to deal with that kind of stuff. I mean, my boys are 2 and 3, so I have a long way to go. But I can see that happening. I can see that potentially being a thing, and I would love for there to be more I don't know, awareness and education on that kind of thing as they're going through school, and it's not just super high pressure all the time.
Yep.
So I don't know if that's the reason for it or not, but
yeah, it could be part of it. Yeah, for sure.
So we talked the last thing I really want to talk about before our time is up and we get into more of the fun silly questions. So yeah, I know. Just be prepared. Would be, so we talked about it's like a sliding scale of how complex or kind of how more simple your patients are in how many patients you can see per day. What do you remember, like, I can't remember when it was, like 2017 maybe, when there was, instead of it just being a PT evaluation code, they changed it into low, moderate, and high complexity. Like you could charge. Do you remember that? So they have this system now where any evaluation that you see, you can charge 97161, which is a low complexity, 162, which is medium, and 163, which is a high complexity. And there's all of these freaking factors that go into it, into like what you deem as that. But then I'm like, okay, so if they want us to charge 97163 for something that's like 45 minutes or greater and people have 3 or more problems or whatever, how are we supposed to know that on the front end when we're scheduling them? And I'm just like, is there some sort of screening that we can do ahead of time? And is it like, so has anything in PT education come up on that topic specifically? And do you have any comments on like how we could potentially solve that problem of how we could time manage better with complex patients?
Yeah, that's a great question. I mean, we have a like a pain sciences class now.
Like a full class on that?
Yep, it's only 1 credit. It's in the 3rd year, but
wow.
I designed it and I teach it, so I like it. And we do talk about that. Like, all right, you're in a busy clinic. How do you make this work? How do you work with a patient that has complex, persistent pain issues? And so we sort of discuss that in terms of like scheduling, and you can still do it even if you don't have an hour one-on-one. You can try to make it work as best as you can. But in terms of like screening them ahead of time, that's a really good thought. It's not something I've thought about a whole lot. I mean, I guess if you had like your forms they fill out online, maybe like a start back, or an Arebro or something like that, to, all right, this person's kind of a high risk patient, or they have they score a certain score on the Arebro, maybe then ahead of time that, okay, this could be a person that's going to need a little more time, but that doesn't always pan out anyways, though.
I know. So I'm wondering, and maybe this is my next like entrepreneurial situation, but maybe I'm like wondering if there's some sort of algorithm. Don't steal my ideas, anybody who's listening. But so I'm wondering if there's some sort of way that we could, like an algorithm that would help to dictate, okay, this one's going to be a low, this one's going to be a medium, this one's going to be a high. And then all of that information that you get ahead of time could like auto-populate to your chart. And I'm giving away all of my proprietary ideas. This is a terrible situation. But like probably nobody's going to listen to this anyway, so it doesn't matter.
Like those kinds of questionnaires are not, they kind of get you in the ballpark, but they're not super accurate all the time. I'm sure you've had it, like a patient fills out the start back and they're high risk, but they just have acute back pain, so they're kind of distressed by it. You work with them, you talk to them, and they're good to go. And
they're chill.
Yeah. So it doesn't necessarily always pan out.
Yeah, I had a patient. So anybody who knows what the LEFS is, the lower extremity functional scale. Are you guys still using that? Is that still a good, like a decent? Yeah. Okay. Well, yeah, it's okay. So I want to know what are the like best outcome measures, because I haven't been in school for a while. But anyways, I use the LEFS sometimes, and I had a patient score like a 10 out of 80. So an 80 out of 80 is considered like, that's the highest score that you can get, and the highest is a good score. So a 10 is like, whoa, you're thinking that this dude or this woman or whatever is really messed up and like, or really has a poor understanding of or a poor perception of how their physical abilities are. So but then this guy comes walking in and he's just like, yeah, I'm just like having a lot of trouble with this. And he was more like mentally distressed by it than anything. And then after I showed him like, yes, you're able to bend over and you're able to like step over this stuff, he was like, oh yeah, I guess you're right. So like it's you're right that the questionnaires aren't always the best thing. So, but I do wonder if it could help with efficiency.
Yeah.
We'll see. Well, so Bill, okay. I've got some good questions for you, and okay. These were questions that I had I recorded another podcast earlier today, and I asked my cousin these same questions. So I want to see how you reply. So the first two are would you rather's, and the first one is, would you rather be in jail for a year or lose a year off your life?
Man, it's a good question. That's kind of the same thing. I guess I'd rather be in jail for a year.
So that's what I said. Yeah. And I think that's what Matt said too. So why did you answer that way?
Well, you're still living and you could still have that experience and memories, and maybe you could take that year to, I don't know, do something, write a book, some sort of personal growth opportunity, learn the prison system.
Such a good, yeah, learn the prison system. That's a good one. Okay, good answer. So the second one is, would you rather live, if you had to choose and you had to stay there, would you rather live the rest of your life in a sailboat or on an RV?
Ooh. Could you go anywhere in either one of these?
Oh yeah. You just like you can't move into a house. You like can't stay at a hotel. You like have to live your life. Though that's where your house is or your home.
I guess an RV. I think I'd have more options. I'm not a big boat guy. Anyway, I mean, I could be on a boat, but it's not like my thing. So drive around an RV. You can kind of go anywhere. So
yeah, cool. Okay, and the last question is your preferred seat on an airplane. So let's say you were in an airplane that had 3 rows on each side, and there's like a window, a middle, and an aisle. Mm-hmm. What would be your preferred seat on an airplane and why?
Oh, definitely aisle.
Yeah.
One, man, you got long legs. They just kind of get folded up in front of you. So I'm the guy that sticks my legs out in the aisle, and then the stewardess like bangs them with the
The cart. That was always me, and my husband is always the window guy, so it kind of works out because he likes to like rest his head on the the side to go to sleep. But then when we had kids, so my 2-year-old, so he's 2 now, but when he was little, he's huge, and I'm holding him on my lap because he's young enough to be a lap infant, but his legs are stretched out into the aisle when he's sleeping, and the cart was like every time they just have no mercy. They're just running through straight into him.
Definitely aisle.
Yeah. Okay, cool. Awesome. So we talked a lot about a lot of really good stuff today. Just a lot of problems that I think still we don't really have answers to. And I think that some people have figured out ways that they're comfortable with practicing, and maybe they're not making the most money. Which really is not the point of healthcare anyway, right? But we all like to make money. So then maybe they're not making the most money, but they're comfortable with the care that they're providing in an insurance network. Or you can be like me and go out of network, but it's a hustle, like you
Sure.
definitely have to be very good at what you do. Your patients have to be very satisfied. You have to be kind of on the forefront of, like, my strategy was going out and finding fitness professionals and gyms to have this partnership with to refer, and that's been an awesome thing for me.
Sure.
But that might not be everybody's thing. So
Right.
So it's like a big struggle across the board, and who knows what's going to happen to these giant healthcare systems that are just sucking at the lives out of everybody. I mean, it's hard to be a private practice.
You're not making a lot of money right now because people aren't going for treatment. They're going to the hospital, so it remains to be seen.
Oh my gosh, you want to know what's funny? And I can say this because I'm totally independent. UPMC comes out with this thing on the Pittsburgh News, and it's like the CEO or whoever's high up there, and they're like, if you have a problem, we really want you to come to the emergency room.
Oh boy.
Because we really, we want to ensure that you are getting the right care, and don't be afraid of COVID-19. And it's like, what? Like, okay, sure, dude. Like, we're all going to go to the emergency room with our ankle that we can probably like heal in a few days.
I mean, I think people are like probably dying at home from heart attacks and strokes because they're afraid to go to the hospital. So I don't think that was the reason for their commercial, but
yeah, no, I know. I'm being silly. But you are totally right. I think that there are people. Yeah. You're right, Bill. Yeah, Bill. So like, I'm a little crazy, and Bill has definitely always been the voice of reason. Bill was my advisor.
That's right.
Oh my gosh, poor Bill. I'm sorry. I'm really sorry. You had to deal with me as a young PT student. Okay, so wrapping up here. Bill, people can find you on Twitter at Egan, EGAN_W.
Yep.
Anything else that you want to say or share with anybody about your life or anything?
I think we covered it all. Yeah, you were a very good interviewer. We covered a lot of ground.
Cool.